Hello, everyone, and welcome to today's lecture. Our topic is sarcoidosis, a unique inflammatory disease that often involves the lungs but can affect many other systems throughout the body. Definition and overview. Sarcoidosis is an interstitial lung disease and an inflammatory multi-system granulomatous condition of unknown cause. While it can involve virtually any organ, about 90% of patients show thoracic involvement, meaning the lungs and chest structures are most often affected. Sarcoidosis typically presents between ages 20 and 40, is slightly more common in women, and has a higher prevalence in African Americans. In the U.S., estimates suggest about 10 to 20 cases per 100,000 people. The exact cause is unknown, but sarcoidosis is thought to be a hypersensitivity response to an external trigger, such as bacteria, fungi, viruses, or chemical exposures, in someone who is genetically or immunologically predisposed. This immune overreaction leads to the development of non-caseating granulomas. A granuloma is a cluster of macrophages forming a nodule. Unlike the granulomas seen in tuberculosis, sarcoid granulomas are non-caseating, meaning they do not undergo necrosis in the center. In the lungs, granulomas infiltrate tissue and may lead to fibrosis, which reduces lung compliance, decreases diffusing capacity, and results in restrictive lung disease with reduced volumes. Clinical manifestations. Sarcoidosis often begins insidiously, with a slow onset and few obvious symptoms. Pulmonary signs: dyspnea, cough, hemoptysis, congestion. Other organ involvement: uveitis, eye inflammation, joint pain, skin lesions, or granulomas in the liver, spleen, kidneys, or nervous system. Systemic features: fever, fatigue, anorexia, and weight loss. Granulomas may resolve spontaneously or progress to fibrous tissue formation, leading to chronic complications. Assessment and diagnostics. Diagnosis requires a combination of imaging and tissue confirmation. Chest X-ray or CT may show hilar adenopathy, enlarged lymph nodes in the chest, and nodular or miliary lesions. Biopsy, either by mediastinoscopy, transbronchial sampling, or in rare cases, open lung biopsy, confirms non-caseating granulomas. Pulmonary function tests often show restrictive disease with reduced total lung capacity. Arterial blood gases may be normal or may reveal hypoxemia and hypercapnia, depending on severity. Medical management. Many patients experience remission without treatment. However, when symptoms are significant or organ function is threatened, therapy is needed. Corticosteroids are the cornerstone. Oral prednisone reduces inflammation and helps control pulmonary, ocular, skin, cardiac, and hepatic involvement. Treatment typically continues for 12 months in tapering doses and longer if relapse occurs. For patients who cannot tolerate high-dose steroids or who fail to respond, immune modulators like methotrexate, azathioprine, leflunomide, or mycophenolate may be added. It's important to note that corticosteroids relieve symptoms and prevent disability, but may not change the long-term course of the disease. Because no single test monitors progression, follow-up requires multiple studies across the affected systems. Nursing management. The nurse's role centers on support, education, and monitoring. Teach patients about the purpose, dosing, and side effects of corticosteroids. Encourage them to promptly report any worsening of respiratory symptoms. Reinforce that sarcoidosis is a chronic illness, requiring follow-up every 3 to 6 months. Provide psychosocial support, as the disease can be unpredictable. Refer patients to resources such as the Foundation for Sarcoidosis Research for community and educational support. Conclusion. Sarcoidosis is a challenging disease, sometimes silent, sometimes multi-system, and debilitating. Nurses play a critical role in helping patients understand their treatment, manage long-term follow-up, and access supportive resources. With proper management, many patients achieve remission or live with stable disease.